Thank you, Pradeep, for that wonderful overview of the proton pump inhibitors and its effects on the kidney, and especially the association of development of chronic kidney disease and acute kidney injury, hypomagnesemia, and maybe even hyponatremia in these patients. So we have some questions which have come from various places. Before I take these questions, I have one question which I think you should. What will be your guideline to the clinicians? There are a lot of clinicians now across the country. What do you think would be the criteria by which you would select, and in which kind of patients would you select proton pump inhibitors if you had to use these agents, and for how long would you think would be the ideal usage for these drugs?
This is a very important question. Thank you, Dr. Kher. I think we should avoid using these medication when it is not indicated. And I use in these medication only in FDA approved indication. So most commonly, what we do is patient comes to us with dyspeptic symptoms, he wants immediate relief, which can be given by many other medication, including H2 blocker. PPI is not needed, so I will avoid it. And most of the studies have shown that more than 3-month use of PPI is associated with increased risk of CKD, and their comparative group was less than 3 months. So we do not know what happens in less than 3 months, but acute interstitial nephritis can be seen in 1 week time. So that is best I can give answer to whatever literature is available. But longer duration of PPI use up to 2 years has definitely increased risk.
Yeah, there is a question from Dr. Jayanta Bhattacharya from Rajganj, and he is wanting to ask you, how is kidney affected by regular use of PPIs for more than 15 years? I would wonder whether there is an indication for continuous use of PPIs for 15 years or so. I don't know which condition would you think there would be an indication for this. I don't know, Dr. Jayant Bhattacharya has asked this question. I wonder whether there is an indication for such a long use of PPIs.
Dr. Bhattacharya, I am nephrologist, not gastroenterologist, so it would be difficult for me to answer, but it is very difficult to fathom a indication which will require PPI for 15 years. It is like antidepressant medication. In United States, I am not a psychiatrist either, but I see if you start antidepressant medication to somebody, I looked at it, you need to try to stop it in 3 months and do not give it for more than 1 year. These patients are on lifelong antidepressant. So sometime what happens is, you start somebody PPI, they get better, then they don't need your prescription, they just buy it over the counter, isn't it? So many times, even if you don't tell them to use it, they use it.
Yeah, another question, Pradeep, is from Dr. Rahul Tiwari, and he is from Mumbai, and he is saying that is this a class effect, or is there a particular PPI which is more prone to cause acute or chronic kidney disease?
That is a good question. I forgot to put that slide actually, or I did put that slide, but I didn't highlight it. It is a class effect. All PPIs have shown to cause chronic kidney disease and acute interstitial nephritis and hypomagnesemia.
Okay. Thank you, Pradeep. And Dr. Rahul Tiwari again from Chembur is wanting to find out, does PPI, intravenous PPI, cause hypermagnesemia? I don't know if he has seen some patient with hypermagnesemia. Have you come across anything since you've done a literature review of this subject? Did you find anybody?
I did not. And no, I did not see it. And actually, if you look at oral PPI, it is absorbed in stomach. It doesn't reach to ileum by GI route. It is absorbed and goes through the blood. So even if you are giving IV PPIs, it can cause hypomagnesemia.
Thanks, Pradeep. Another question, Dr. Tobe from Bangalore. What is the risk of PPI-induced acute interstitial nephritis, and what would you consider the prognosis of acute interstitial nephritis?
Okay, so as I said, the best data comes from New Zealand. They have done a national nested case control study where they looked at all the patients who had acute interstitial nephritis, either biopsy proven or suspected. They found risk of acute interstitial nephritis, definitive acute interstitial nephritis, which you can say it to to PPIs was 8 per 100,000. So risk is not a big risk, but it is there. Now diagnosis is difficult in a sense because most of the symptoms of acute interstitial nephritis, which we read as nephrologists, are not there. So you need to check renal function within 3 months and see what happens.
Thank you, Pradeep. There is another question. Do you think there is a safe duration of usage of a PPI as such, or even a few days of CPI might predispose a particular patient to development of chronic kidney disease, or which kind of patients you would say that should be avoided totally? Do not use it in these kinds.
I mean, more than 3 months we should avoid, because if you look at all the papers, they are based on comparing to less than 3 months duration. So the hazard ratio was 1 for less than 3 months, and after every 3 months uses, I would avoid PPI if I can avoid completely. But if I have to use it for FDA approved indication, use it and bite the bullet. But if we can stop this medication within 3 months, we should. And as far as acute interstitial nephritis is concerned, it is a idiosyncratic reaction. So we talk about usual time period is 1 week to 9 months. So it can happen in 1 week use. And it would be very difficult to give you answer if it is 2 days duration or 3 days duration.
Well, I think there are good number of questions coming from Mumbai. Dr. Sarvesh Agarwal wants to say that if we have to shift, as you suggest, the patient is on PPIs, or how do you shift a patient from PPI to an H2 blocker? Is there a method, or you can say that you can do it anytime? There is no reason. Any method?
I think I'm not, again, Dr. Kher, you know, I'm not a gastroenterologist. I do not use this. So I am the wrong person to answer this question, but I have not read anything that you have to taper it down and then start H2 blocker. I did not get that part in the literature.
Yeah, in my simple way of thought process also would be that if you find that actually accidentally you find that the patient has been taking this drug for so long period of time, I would tell him to stop this drug and use an H2 blocker. That would be probably the best way. Now, in a patient of already chronic kidney disease, I think as you showed that there is a progression of chronic kidney disease. So I think chronic kidney disease patients would be a specific group of patients probably where I would want to avoid using proton pump inhibitors, especially from the kind of data that you showed that there may be an evidence to suggest that this may be causing progression of to end stage kidney disease. Would you agree with that?
Yes,
or?
absolutely, Dr. Kher. If patient, we do not have a FDA approved indication, we should not use it. We should avoid this medication as much as possible. We should. I agree with you, sir.
Now, if you were to you were using this drug, would you recommend monitoring magnesium levels in these patients, or you should look at only for symptoms of these patients and then check magnesium in these kind of patients?
No. I think whenever you start PPIs, you need to monitor magnesium level, because that is, magnesium may not, unless it goes down below 1.4 quite a bit, you may not be seeing symptoms, but you may see other side effect like there is an increased risk of endothelial dysfunction, there is an increased oxidant injury, there are a lot of things which magnesium does. So no, I will monitor. In my practice, I actually monitor their magnesium level in CKD patient as well as in dialysis patient.
The other question I have is that in patients who are there are patients who consume PPIs without, since these are over the counter drugs, and especially in India you can get any drug for that matter without a doctor's prescription. Now I think there is a need to increase awareness about these drugs, because most physicians as well as patients continue to believe that these are very safe drugs and they don't have any side effects, and continue to consume these like as if these are sweet meats for them. So would you think that there has to be a greater awareness about the misuse of these drugs across the counter?
Absolutely, sir. You have said it absolutely. I cannot say it better than that. It is being used as if we are taking B complex every day, and problem is here in United States also PPIs are available over the counter nowadays, but they are very expensive compared to prescription. So that is a one deterrent in United States. I do not know what is the cost of PPIs, and people take it anytime they have some acidity after the food. I mean, I know my family over there. They take it.
Yeah, there is a question from Faizabad, and I think they are saying that long-term use of PPI might cause iron deficiency anemia, because they may not allow iron to be absorbed as such. And do you think that that is also an important consideration?
It is possible, but I didn't. Iron deficiency was not one of the side effects mentioned in the literature. B12, yes, but iron deficiency. I had shown that very full figure where I had given so many side effects, like tuberculosis causing head to toe side effect, like PPI causing from head to toe.
You already answered some of this question, that how long use of PPI need to be taken to cause chronic kidney disease. Does it occur in all patients? So obviously you've shown the data that it's longer the use, the higher the chances of development of chronic kidney disease. And if you continue to use it in patients of chronic kidney disease, you will continue to cause progression of damage and leading this patient to end stage kidney disease earlier. So I don't think that needs to be, it just needs to be highlighted in these kind of situations. You also explained, I think probably some of the doctors in the audience may not have understood the mechanism of hypomagnesemia, but I thought that you did it excellently, actually giving the tubular mechanisms. And nephrology always remains a difficult subject once you get into the physiological basis of various pumps and all the enzymes and other methods of movement of these electrolytes across the tubular lumen and into the tubular cells. So this seems that probably they may not have understood this. So it is obviously tubulopathic genesis of hypomagnesemia, and they are saying that is chronic kidney disease also related to hypomagnesemia in some way, or is it?
So, Dr. Kher, hypomagnesemia due to PPI is related to GI decreased absorption. It has less to do with renal excretion. So, if we look at hypomagnesemia, as I said, TRMP6 is present in intestine, duodenum, jejunum, and it blocks TRMP6. So, it is a GI absorption which is decreased. So, fractional excretion of magnesium in these patients is 2. Kidney disease due to PPIs, acute interstitial nephritis, which is undetected and lead to chronic kidney disease. And number 2 is hypomagnesemia leading to endothelial dysfunction, leading to interstitial fibrosis directly in a rodent model. Yes, so it has a direct effect on the development of chronic kidney disease, hypomagnesemia.
Okay, another question is that do you think that intermittent use of PPI, say given for 2 weeks and then again after some period of time, if you can use, is that safe, or you think that that also would be
It
detrimental?
would. So if you look at the epidemiological database, so VA has all, once patient take prescription from us, we have all the database. It is most of the time not continuous. It is every 3 months he has taken a 1 month prescription. So it is not that you can take episodically and feel good about it that it is not going to harm you now.
Another question.
Yeah, I won't agree with that part.
Yeah, another question is that if you are using PPI for an FDA approved indication, now what are the precautions you would take to prevent acute kidney injury? Is there anything that you can do to prevent? Unfortunately, that's
Unfortunately, it is idiosyncratic
yeah.
immunological reaction,
And another question is, does PPI have any effect on mortality in patients with end stage kidney disease? I think you showed some
Yes,
data.
it is. It is. Yeah. So PPI across the board, I didn't see a single paper where PPI use was not associated with increased mortality in general population, in cardiac patient, and other group. And in ESRD, hypomagnesemia is associated with increased risk of death. Yes.
And if you were to use this drug in chronic kidney disease, one of the doctors is asking, how frequently should you monitor eGFR in these patients if you were to use this?
And it depends how frequently. It depends on the stage of the patient. In United States, in stage 3, we cannot see them more than every 3 months. So in stage 4, we see them every 2 months, and in stage 5, I see them every month. So it depending upon the stage and how much insurance is going to pay. That is the reality in United States, unfortunately. So as it is not popularly known in India, it is not even known in United States very much. And we have to bring actually awareness of this medication causing this. When I presented this in 2015 in ASN, there were hundreds of interviews taken, including CNN, NBC, from me and other investigators about, at that time it was, there was a news, but after that you never hear about it.
There is, Pradeep, a question from your old alumnus. Should PPIs be avoided in patients on high dose steroids? Although steroids itself is a treatment for an acute interstitial nephritis.
Yeah, I mean, as you know, it is Harbir.
No, I don't know. This is from
Harbir?
This is from HGPJ Lucknow.
I mean, if you look at if you look at the use of steroid in PPI in steroid preventing GI bleed, if you look at the literature, it only prevents GI bleed if there are underlying erosions present, isn't it? So if patient had normal stomach, they do not need PPI to prevent stomach ulcer. So you can use H2 blocker in those patients if you have to. The second part of the question was, what was the other part of the question?
Although he thought that can use of steroids prevent development of an acute interstitial nephritis, and would that be an indicator?
Steroid. If you look at it, steroid does not cure all the acute interstitial nephritis, isn't it? So, yeah. But and obviously we do not have data on this. So it is, if you remember, Dr. Kher, we have published a paper on acute interstitial nephritis.
Yeah, long time back.
Steroid did long time back. Steroid didn't help.
Yes, that's right. There is another question from Kolkata, and that is H2 blockers. They are superior to PPIs in this context, and so can they be used for a long-term usage, or what do you think? People are not going to leave you.
I wish I would be more confident to tell you this part, but whatever data we have is coming this year, And based on that, we know H2 blocker is safer than PPIs. But long-term use, maybe after 3-4 years, we may know something, but right now we do not know. And H2 blocker can also cause hypomagnesemia, but to a lesser degree.
Yeah, I think Pradeep, there are still some questions coming, and I think I know that Pradeep wife is waiting. He has a date with his wife after I think 25 years. I can tell you. So we should let Pradeep go and have a date with his wife. And I must say that thank you Pradeep. And I hope Amita should thank me at least allowing you to go over and
Thank you, sir.
have lunch with you. And I must thank all the participants from across the country for showing such a great interest in asking questions. I know that there are some questions which may not have been answered completely, but I would agree that this is something which needs to be known by the physicians. There is a greater and greater evidence accumulating in the literature about the use of PPIs associated with acute kidney injury, chronic kidney disease, increased progression of chronic kidney disease, development of hypomagnesemia, and they may be associated also with hyponatremia. So whenever you see a patient who are on unnecessary sort of prescriptions of PPIs, in fact actually all unnecessary prescriptions. If I look at a patient, at least in many of our patients, there are 20 drugs which patients are, and I am sure when I look at them, 10 of them can be easily removed in these patients. So I would suggest that every physician must look at the drug list of a patient and see whether they can cut down that drug list. It is